Richard Vautrey, of course, is well known to everyone. He's the chairman of the GPC, chairman of the negotiators, and we're really, really grateful to have him here today. As you can imagine, in the midst of this, the GPC are more than a little busy trying to sort things out. There have been contract negotiations, of course. There have been tweaks to the contract. We have had some financial guarantees, of course, for practices, which have been hugely important as we work through. I'm sure people will have thoughts and questions. So in the usual way, if you could pop those in the chat, and I'm hoping we will have a chance for Q&A session at the end. Richard only has an hour, unfortunately, because he's got other things to do. So if you could keep the questions short, that'd be super. But Richard, thank you for coming. You have the floor.
Thanks very much for inviting me. And as Greg said, we've obviously had a complete focus on the pandemic and the impact that that's had for many colleagues and many practices over this last year. But we are in an unusual situation insofar as we are midway through our 5-year contract agreement. And so in many ways, much of what I'm going to present had already been agreed. We'd already made these plans and changes with no idea that a pandemic was coming. But nevertheless, it's something that we've been able to utilize, has given us a degree of certainty and stability, but also has enabled us an opportunity to make some modest changes, which maybe we wouldn't have made if the pandemic hadn't hit us in the way that it had. So this is the 3rd year of our 5-year contract agreement, 21-22. And the whole premise is that we are trying to make sure that the changes that we make are supportive of practices and enable them to continue to focus on their pandemic response, particularly the vaccination program. And really from the start, I should give a real huge vote of thanks to everyone who's been involved in the vaccination program. An incredible response that has been really appreciated from every single patient who's received a vaccination, every politician who has thanked general practice from the Prime Minister downwards for the unparalleled response of general practice at this particular time. So amazing achievements, but obviously a long way still to go, which is why we have agreed with NHS England and that minimal changes would apply from the 1st of April, because our focus has to continue to be on that pandemic response and the COVID vaccination program. So this program sets out, also this presentation, should I say, sets out just interim contract agreements that we've made. It's possible that there will be further changes later in the year. Again, once we know how the pandemic plays out, as we see what happens further with the vaccination program and other issues. So it is something that's interim, but hopefully it will give practices confidence that there aren't too many major things that they need to be focused on other than the current situation. This is the funding level that will go into practices from the 1st of April. So an uplift to the contract of £253 million, which includes for pay uplifts at about 2.1%, expenses uplift of a similar 2.1%, and that takes into account a whole range of different factors, population growth, additional Section 7A funding for vaccinations, immunisations, additional funding into QOF, which we've secured now, which I'll mention in a little while. This is at a time when the government has already signalled a wider public sector pay freeze. We don't know what they're going to do for the NHS. They've excluded the NHS from that public sector pay freeze, but nevertheless, it's quite likely that NHS pay is going to be squeezed as the nation as a whole, the Treasury in particular, focuses on trying to recoup some of the costs of the pandemic. But for general practice, we've got security of funding. So we'll see an annual increase for this year of 3% overall, and that's a cumulative increase of 7% for the contract package so far. So a significant amount of new money going into practices. What will this mean to some of the basic figures? So the value of the QOF point will increase to £201.16, that's 3.3% increase. And the global sum value will increase to £97.28, that's a 4.1% increase to global sum. We've also made adjustments to the out of hours adjustment, and this is the historic payment since 2004 that's used for funding out of hours activities that practices have now opted out of, and so those adjustments change as the funding level in global sum changes. So two big things to say about QOF. The first is that the biggest change relates to more of a contractual shift rather than a shift in workload pressure. So we have, as part of our agreement, been working on improvements to the vaccination and immunisation arrangements within our contract. We've always wanted to remove the childhood immunisation DES because it had unhelpful cliff edges at 70% and 90%. That meant that many practices didn't get any funding at all for some of the activity that they were involved with. And so what we've done is we've moved over a 2-year period the funding from that and now this year into QOF. And so that's the biggest change to QOF, is that £60 million has been transferred from the DES element of the contract into QOF. But the activity relating to childhood vaccinations remains exactly the same. So it's no different, there's no additional workload, it's just the way that it's measured within our contract. What has changed is an additional £24 million into QOF from April to strengthen the serious mental illness category and domain, particularly with a focus on physical health check indicators. And I'll show those indicators in just a moment. The other change that we've made is a review of the cancer indicator, and we've split that so that it'll now be a focus towards the beginning period, sort of shortly after diagnosis, and then a more detailed review using a structured template later on, sort of maybe a year or two after diagnosis. And again, I'll share the details of that in a moment. So overall, and this is mainly because of the changes related to the vaccination and immunisation shift, the value of QOF, or the number of points in QOF, increases from 567 to 635 points. Importantly, most of the rest of QOF remains exactly the same. So we've maintained the thresholds, we've maintained all of the indicators, and importantly, we've maintained the quality improvement modules that some practices will have been working on, even though they've been income protected over this last year. Some practices will have started doing audits, started looking at reviews relating to learning disabilities and supporting early cancer diagnosis. That work can be transferred into this next financial year. So you don't have to do it again, so you can build on it and utilise that to fulfil the quality improvement modules, which will be the same with some slight tweaks reflecting the changes in the pandemic. But the focus will again be learning disabilities and supporting early cancer diagnosis, because we felt these were important areas that practices should be focusing on and trying to seek improvements in if they could do so. Of course, it goes without saying that remote working, when clinically necessary, will continue to be an acceptable way of delivering QOF reviews for the foreseeable future. So this is the detail of the indicators that will be changing in the coming year. So in terms of the SMI domain, there's a return of the indicator relating to alcohol consumption. This was previously in QOF, it was dropped and it's now been brought back again because it was felt to be important. And then two new additional indicators relating to the checking of lipid profiles and HbA1c, looking for early warning signs of cardiovascular risk factors, which we know this group of patients are at higher risk of. So this is about addressing health inequalities, it's about improving the care to patients with serious mental illness, and hopefully trying to avert some of the physical morbidity and mortality that this group of people are predicated to have and experience. You'll see that the lipid profile indicator could be done every 2 years because it's not necessary for everyone in that category to have a lipid profile done every year. But it's quite likely that most practices will do it every year because the need for a blood test for an HbA1c or blood glucose will be an annual requirement, and so you may well want to do the lipid profile at the same time and obviously act accordingly. So you can see how we've split the cancer indicator into two. So there will now be a focus towards the beginning of someone's journey with cancer within the first 3 months of diagnosis, just checking that they've had the opportunity for an informed or supportive discussion with primary care. Now, that doesn't have to happen. It's just providing that opportunity, because we know that in most cases, many people will be receiving their immediate care and support from the hospital and the cancer services. There's a second indicator now, which will be within the first 24 months following cancer diagnosis, and that's utilising the cancer structure template that's already in your practice systems, and using that to focus on a wider discussion around cancer, how it's impacting patients, whether they've had any particular issues or concerns, and that's sort of something that the Macmillan have been encouraging practices to focus on. And as I say, the template is already in your systems for that. So a little more about the vaccination and immunisation changes. So the additional service that was funding the routine activities of vaccination and immunisation services, the funding for that has been fully retained within Global Sum. So not a bit of money has been lost, and we've retained that. That's to recognise the work that all practices have in terms of call and recall, administration of vaccination and immunisations, and the dealing sort of, with other immunisation related issues. As we've seen with the pandemic, if we have major or national outbreaks relating to vaccinations, then that would be agreed separately, as is quite clearly the case with the COVID pandemic. So what we've done with the childhood vaccinations, this is something that we started work on last year. It applied to MMR last year, but it will apply to all childhood immunisations this year. From now on, every single childhood immunisation that is given will attract a standard vaccination and immunisation fee of £10 and 6p. You'll see this is the same fee that applies for seasonal flu vaccines, and that's now being used as the benchmark for vaccinations generally. Remember, just a few years ago, this fee was much lower. We managed to increase the amount, and so now it's more reflective of the activity that takes place, and that will apply to each and every childhood immunisation that you give. However, there is a caveat to this. We do want to ensure that practices do continue to achieve good levels of uptake. And so the immunisation fee for practices achieving less than 80% of the target cohort will be modified, almost in a sliding scale type of way. This is the way it will apply. So what will happen is that practices will not receive the fee for the first 50% of their cohort, but they will receive the item of service for each immunisation received above that 50%. And once you get to the 80% level, then you'll receive the equivalent of the £10 and 6p for all of the patients. So it does mean that, as we've seen previously, practices that say only got 67% of their immunisation targets, they never received anything at all because they hadn't hit that 70% initial threshold for the childhood immunisation DES. Now practices will receive some money because they'll have started to receive money above that 50% level up to 67%. And if they get to 80%, they'll receive the whole item of service fees for all of the patients that they've given. So a significant improvement for practices that struggled to achieve even the lower levels. But we would hope that this provides a new opportunity to actually increase funding into the contract, because if practices go above and beyond what they've historically done in terms of activity, then they should receive more as a result, and that would draw more money, new money, into the contract as a result. So we hope this will be a benefit both to patients in terms of uptake, but also to practices in terms of having additional opportunity to earn further funding. In limited circumstances, where practices have real challenges of achieving uptake for patient or patient lift demographic reasons, then it may be possible to retain the full payment, rather than having some of that payment modified. But that would be a local discussion. But that would be in extreme circumstances. But the potential is there, because we know that there are some situations where even with the best intent, the practice isn't possibly able to get to higher levels of achievement. So as I've said, the 70% and 90% cliff edge immunisation targets, they will be removed from this year. We're still working with NHS England on exactly how this will work, but we intend there to be a monthly aspiration payment similar to QOF, because most practices' immunisation levels are fairly stable. They might increase a little bit, drop a little bit year on year, but similar to QOF. So we would hope to be able to make some form of aspiration payment, so you don't have to wait for the full end of year to get your vaccination immunisation payments as a whole. Additional investment means that significant majority of practices should actually gain from these new arrangements. And it's also worth saying that the Investment and Impact Fund, the IAF funding, will also encourage influenza uptake at PCN level. That's something that started this year, and that's something that will continue going forward. So these are the indicators that will now appear in QOF. So it's worth remembering when you look at the payment thresholds, which are linked to the World Health Organization targets, that these are in addition to the payments, the item of service payments that practices will receive. So they'll be receiving the payments for vaccinations given to all children. And then in addition, should you reach these thresholds, then you'll receive additional funding as well. And what we've done for these indicators, and uniquely for these indicators, is we've weighted the points to start at that opening threshold. So as soon as you hit that 90% threshold for the first two indicators, you will get 3 or 7 points respectively. And similarly, sort of, with the MMR indicator, if you achieve 87%, then straight away you'll get 7 points at that threshold. And then the weighting will increase beyond that for the total of the 18 points, should you get to 95%. So the normal sliding scale will then apply. So again, this will try to mirror the current level of achievement that practices are getting. So most practices should get what they've previously got through this new arrangement. But if they do more, then there's an opportunity to earn more as a result of these new arrangements. You'll all be aware that one of the big risk factors that's been evident for COVID-19 has been obesity. And so as a nation, we need to do more to try and help our patients, to help ourselves, maybe tackle sort of the obesity situation and support people with better weight management. So we've agreed to discuss this in the coming year about what arrangements we could put in place to try and support this. This is likely to take the form of some form of enhanced service, and we'll look to try and ensure that it mirrors what is locally available. So we want to make certain that every area has accessible weight management services, because this is not something that practices can do on their own. If you've identified patients who want and need support for weight management, then there needs to be a locally accessible service, and we need to ensure that the pandemic doesn't limit referrals to appropriate weight management services. So there's some work to be done on this, but there is a commitment from government and Number 10 in particular, to provide additional funding to support a new enhanced service that we'll produce later in the year. So you can see here the current status relating to PCNs. So we know that 99% of practices are now involved in their PCN. There's over 1,200 PCNs across the country, and a typical PCN has a population of around 48,000. But you can see there's quite a spread, even up to a size of over 200,000 for some very large PCNs, but they're the minority. You'll know as well that the LMC England conference mandated us to have a ballot on the PCN DES, and that's exactly what we did. Even though we knew it was going to be challenging at this time of the year, sort of with the pandemic, we had the ballot in January, and you can see there the ballot question asking whether those who respond would give GPC England a mandate for the PCN directed enhanced service before any further changes were made. And you can see that we got an 80% support for that, and so we've progressed on that basis. As I said at the beginning, many of these changes and funding arrangements were already agreed. And so the payment that practices receive just simply for engaging sort of in their PCN will continue at £1.76. There will continue to be payments made to core PCN funding. What has changed slightly is because last year, or the year that we're in at the moment, we've only had half a year's payment for the care home premium, because the care home enhanced service or the care home service specification only started mid-year. It will apply for the whole of this coming year, and so all of your care home beds will now receive a premium of £1.20 per bed. What is the biggest change this year is the increase to the ARRS funding. This is the funding for PCN workforce. which will provide for a significant expansion of the workforce, with funding increasing nationally from £430 million to £746 million. So a real opportunity to recruit more staff to work in our practices to help manage our workload pressures. And remember, these are staff as well who can be deployed in vaccination services, sort of and other services linked to the pandemic, and can really make a difference to supporting practices. And there's a real opportunity, particularly at a time when the nation sort of is looking at rising unemployment, sort of, and real pressures, sort of, for others, to have an opportunity to recruit more people into general practice through this funding that is guaranteed. Also, a big increase will be the IAF funding. Will increase from £24.25 million this year. You'll remember that this year, some of that funding was amended. Again, the first 6 months didn't happen and the funding went direct to PCNs. And the small amount of money that was left was used for a limited number of indicators. That will increase significantly next year to £150 million. One area that has changed is the access scheme. The funding remains the same. So in total, there's £454 million available for the access scheme. That's £87 million for the extended hours scheme. That's the extended hours that most practices were involved in doing. It's now a PCN responsibility, but still many practices do it themselves. But in addition, there's £367 million being spent nationally on the extended access scheme. That's the evening and weekend appointments that currently many CCGs commission, sometimes from local practices, local federations, or other out-of-hours organisations are delivering that at the moment. The intention had been to move that funding to a PCN responsibility in total from April. But because of the pandemic and the need to give notice to those who are already providing that service, we've delayed full implementation until 2022. It does mean, though, that those practices that are currently doing it can carry on doing it, or those PCNs that are currently doing it. And if you've already got plans in place within your PCN to take over responsibility from your local provider, maybe mid-year, that's something you can still do if there's local agreement to do that. But there isn't any expectation to do that until April next year. So this is an overview of the DES changes that have previously been agreed and some of the changes that we've now agreed in the last few months. So as I've said, the ARS funding will increase. There's also an expansion of opportunity for employment of different ARS roles. We saw that midway through last year where we extended the roles from 10 to 12 with the inclusion of nurse associates and training nursing associates. But now we've expanded it further to include paramedics, advanced healthcare practitioners and mental health care practitioners, and I'll go into a bit more detail about those shortly. As I said, the IF funding increases to £150 million, and it will increase further again in 22-23. What we have delayed because of the pandemic are the 4 service specifications. They will not be introduced until April next year. So this will be given reprioritisation sort of, because of the pandemic situation. There will be a phased approach to the introduction of new IF indicators from 21-22. So they will happen later in the year, and we're likely to see sort of, well, we will see further discussion with NHS England on those, and we'll let you know as soon as we have reached agreement about what they will be and how they will apply. But you don't need to worry about those from April. And as I've said already, the access offer is delayed until April 22. One other change that we've agreed is that the clinical pharmacists who are still on the clinical pharmacist in general practice scheme can still be transferred to the ARS funding arrangements and there's still a window to do that until the 30th of September 2021. So we've extended that window opportunity. It won't affect practices locally here, but certainly in practices in London, we're struggling with recruitment because of the inability to apply a London weighting to their salaries. They will now have that opportunity. They can use their increased allocation to do that for London practices. What we are also seeking, and we've yet to agree this, but we recognise the huge pressure on clinical directors and those who work with clinical directors, practice managers and others, and we really were pleased to see the agreement of additional funding in this current quarter 4, for clinical directors, so a full whole-time equivalent payment for them. We think that should carry on, and we're seeking that should be at least continued for April, May and June, and we're pushing NHS England to make that change and make that agreement. So a few words about the various new healthcare professionals who you can recruit within your PCN. You will now be able to recruit paramedics. And I know that some PCNs have already got paramedics working within them as part of various pilots or shared care arrangements with their local ambulance service. But this will now allow the PCN to employ paramedics themselves if they want to do so. And all of this is voluntary. This is how you use your allocation. It just gives you more flexibility. So if you could now employ a band 7 level paramedic with the necessary skills and abilities, so they would need to have that level before you can employ them. If a paramedic doesn't yet have level 7 capability, then they can be engaged, but it would still need to be via a rotational model as part of a training pathway with your local ambulance service or other provider until they achieve that level. But once they achieve level 7 capability, then you can employ them directly yourself without the involvement of the local ambulance service. There are a number of healthcare professionals where it's possible to develop advanced skills and thereby be paid and reimbursed at band 8A, so significantly skilled individuals. This would apply to clinical pharmacists, physios, occupational therapists, dietitians, podiatrists, and paramedics. They need to have the necessary skills. That's often a master's degree level, but if they have that, then you can recruit them. Again, it'll be limited in the first year to 1 AAP per PCN for the vast majority of PCNs. Those that are much bigger will be able to have 2 because of their size, but in relative terms, it will be the same treatment. HEE will be developing a registration process for this. So this is expected by October 2021. So these are not somebody who can just say, well, I've got the skills, pay me at this rate. They have to be demonstrably working and have the necessary registration arrangements for this to apply. One of the big changes that we're making this year is the introduction of the opportunity for PCNs to take on mental health practitioners. Again, this is voluntary. You don't have to do this. You may already have good arrangements and links with your mental health provider and feel that that's sufficient. But if you want to employ additional mental health practitioner or have them working with you and embedded within your PCN and your practices, then now there's an opportunity to do so. The difference here is that it will need to be in partnership with your local community healthcare provider. So your mental health trust or your community mental health service provider, they will need to work with you sort of on this, because they will be expected and mandated to provide 50% of the funding for this role. So for a whole-time equivalent mental health worker, the PCN will only need to provide 50% of the funding. So they'll effectively get the other half of the individual free. So this draws in more money into the ARS in addition to what we'd already agreed. For the first year, this will be 1 whole-time equivalent per PCN. Will increase to 2 whole-time equivalents in 2023 and 3 by 23-24. And whilst the focus is on adult mental health practitioners, if you've already got an adult mental health practitioner and what you really want is a mental health practitioner with a focus on children, then that's something that you could consider doing and using this resource for that. These staff will be in addition to mental health practitioners who are already embedded in your practices or within your PCN areas that have, maybe from historic schemes that are already operating. So the mental health provider can't just substitute sort of your current funding arrangement, your current individual sort of with a new individual who's exactly the same person, but just through different funding arrangements. This is an addition. This is expanding the opportunity for mental health provision. The other thing that we're trying to encourage here is to see a focus on the reducing some of the barriers sort of in terms of referrals for patients in this area. So we know that in some cases, patients have practices have really struggled sort of making referrals for patients with mental health problems. And we want to ensure that there is a real opportunity for improved patient pathways to mental health services when it's necessary to do so. As I've mentioned already, those clinical pharmacists who remain on the clinical pharmacist in general practice scheme, that's the old scheme that started before our current agreement, they will be able to transfer to the PCN funding arrangements and be reimbursed under the ARS as part of these changes. But there's only now a narrow window of opportunity to do that and that's to the 30th of September. This really doesn't apply for you locally, but it's just to bear in mind that practices in London can now utilise their funding for local flexibility to pay the London waiting amount. So the services that we currently have at the moment will continue. They will be slightly modified in terms of the medication review and the early cancer diagnosis service requirements. So the structured medication review will be slightly widened to provide an opportunity to include reviews of addictive pain medication, so opioids, gabapentoids and benzodiazepines and Z drugs. There's an opportunity to review those if you've got pharmacists who wish to do that. PCNs could also review and identify any specific actions to address unwanted variation in cancer outcomes as a result of the pandemic, where there's particular changes in your area. And your PCNs will also be encouraged to facilitate the sharing of capacity for cervical screening across the practices, where there is particular problems in one particular practice that's struggling, maybe finding ways to try and support them. And hopefully that's something that the PCN practices could work together on. There are no changes proposed for the care home service requirements. That will continue as it currently is. But as I've said earlier, the funding per bed will increase to £120 per bed. As with all of the current services, there's no targets in any of these service specifications, and they're all predicated on having the people in place, the healthcare professionals in place to actually deliver them. And the related indicators would be included within the IAF once they've been agreed. Now, this is what was planned from April 2021 as part of our agreement. We were looking to agree the cardiovascular disease diagnosis and prevention service specification. This would be about early identification of patients with hypertension, not yet known to the practices, maybe patients with atrial fibrillation and such like, to try and again sort of pick up on patients who have not yet been diagnosed, and so we can try and intervene sort of earlier and reduce morbidity and mortality. Also, as we've seen sort of with the pandemic, sort of, which really exposed health inequalities, and there may be an opportunity for a service specification around looking at areas within a particular PCN that might be beneficial in terms of tackling those and trying to address those. The anticipatory care service specification and personalised care specification was supposed to have been introduced this current year, but again, we delayed those because of the pandemic, and they've been delayed further until later in the next financial year. They will require the involvement of community service providers to be really signed up to this and be involved, and their contracts will be modified to ensure that that is the case. All of these services linked to recruitment of the sufficient ARS staff. As I've said earlier, this funding increases significantly, so hopefully the workforce will increase significantly as well, and we need to get on with that now as soon as we can, even though there's no requirement to deliver the service specifications at this stage in the year. So in order to support practices sort of, as part of this pandemic, we have agreed with NHS England that all of these will be delayed. Similarly, with the Investment and Impact Fund, this has been delayed as well, although we've continued with some of the indicators that are currently operating this year. So you remember that this year we restarted the IAF in October with 4 indicators. One was relating to flu and the over 65s. Virtually every practice will have achieved this very easily this year because of the high uptake of flu vaccine this year. Similarly with learning disability health checks, you not only get paid for doing learning disability medicals, but you also get paid for achieving sort of the threshold sort of for learning disability health checks within your PCN. Social prescribing indicator was related to the number of referrals for social prescribing, and again, most areas will have surpassed that because of the benefit that social prescribers are bringing to people sort of within the pandemic. And then an indicator relating to the co-prescribing of gastroprotective PPIs alongside NSAIDs or anticoagulants, and that will be measured on Q3 and Q4 data. The flu, learning disability and social prescribing indicators will continue in the coming year. And so those are the only indicators that are yet to be have currently been agreed and that will apply from the beginning of this year. We've yet to agree any of the other indicators and how the rest of the £150 million will be applied. So the discussions are ongoing about other potential areas and other indicators, and these are the areas that NHS England are interested in. They want to continue to support the COVID response and tackle health inequalities, something that's been clearly exposed by the pandemic. And that's something we want to work with them on as well, so that we can try and enable PCNs to do something that goes with the grain of what you would already be doing sort of in your local area. That applies particularly to vaccination uptake, not just flu vaccinations, but maybe other vaccinations, and maybe even the COVID vaccination. But I think we need to look and explore about that, about what's appropriate sort of, to put within the IAF that isn't already incentivized elsewhere. Obviously, NHS England want to link some of the indicators and investment to the PCN services when and if they're implemented. So as we say, we've got some indicators, we've got some service specifications operating already, like the care home specification, but then the others that they would want to introduce maybe later in the year. But again, that's completely predicated on what happens with the pandemic. And no one really knows yet what will happen, not only during the summer, but in the autumn and winter to come. There was a prior agreement to use at least £30 million of the £150 million to support access, around improving access and the experience of general practice. What we don't want to do is repeat the mistakes of previous years with the failure of the 24-48-hour access indicators and various other things like that. We don't want those at all, and we're working with NHS England to have something that's much more appropriate. Something that we are keen to work with them on is how general practice can play its part in reducing carbon emissions. That might be through prescribing changes, but also other changes as well to support the NHS's net zero commitment, and something I think that all of us would want to try and play our part in. As I've said already, the access scheme has now been delayed until 2022. We had intended bringing together the two funding streams, the extended hours scheme and the extended access scheme, into one to give PCNs responsibility, primarily so that they could control and have greater opportunity to utilise those appointments in a way that benefits local practices as well as patients. So, for instance, combining the scheme to provide greater opportunity for appointments at different times of the day, to offer things like health checks, smears, immunisations, structured medication reviews, in part to reduce the pressure on core hours workload. We saw that in the early days of the Prime Minister's Challenge Fund, when CCGs funded proper extended access services over weekends. Actually, practices workload on a Monday reduced as a result of patients being seen at other times. So we need a focus on routine work sort of within general practice, rather than the focus that has happened in some cases in some parts of the country, where it's been more about how to reduce the pressures on A&E and how to have an urgent access service. Well, the out-of-hours service is for that. This should be much more about providing additional capacity to support practices to manage their workload pressures, but also give more opportunity and access improvements for our patients. This would also recognise the benefits of digital services, which we've seen throughout the year, enabling more flexibility of home working, sort of maybe doing evening and weekend services by sort of, sitting at home, sort of providing those services, maybe cooperating with neighbouring PCNs, across a bigger footprint might be also one way of doing that. So there's all sorts of opportunities, but it does require PCNs to have the control of the funding to be able to make that happen. But that will happen in some areas already, because they already have these schemes under their belt. In other areas, there may be an opportunity to do it this year, but for the majority, this will apply for April 2022. It's worth mentioning that both GPC England and NHS England are committed to ensuring that all general practice workforce have good contractual terms and conditions. Whilst our focus traditionally is about GPs, we also need to ensure our staff, whether that be salaried GPs, pharmacists, practice managers, receptionists, admins team, whoever they are working for us, we need to ensure that we treat them well and fairly. So we've agreed that we'll undertake a data collection survey to get an accurate baseline of the current terms and conditions of practice staff. And following this, we will develop some good practice guidance on employment terms and conditions in general practice. We would hope that LMCs would support us in that, so that we can ensure that practices, within reason, sort of, using the funding that's available, are providing good terms and conditions to their staff. One other area that's challenging us, and one thing that we need to face up to, is the importance of the gender pay gap. That is evident in general practice, as it is in other parts of the health and public sector, and other organisations. And we need to try to understand it and also try to address it where possible. And as part of that is about how we do that in a transparent way without adding undue burden onto practices, and also respecting individual privacy of individuals, particularly for small practices. So that's something we're exploring about how we could do that in the coming year. As always, each year there are further focus on digital requirements, but this year is unusual in that most of these, if not all of these, are already being done by practices as a result of the pandemic response. So the radical move to remote consulting, the use of online consultations, video consultations, two-way communication between our patients, that is written and secure, our improvement in symptom checker use and self-help information. All of this is being done already by most practices. And so we'd want to operationalize this across all practices in the coming year so that all patients can benefit from it. One of the areas that we are looking at is how we can enable patients to use online methods to inform their practice when there's a change of address or contact details or telephone number changes. So rather than practices having to do this, patients should be able to do this themselves and update things appropriately. So we're exploring how that could help reduce practice workload. It's worth mentioning that there's still a bureaucracy review taking place run by the Department of Health and Social Care, as well as NHS England and Improvement. And we're involved in that. This is exploring changes to fit notes, DWP reports, and other requests that practices receive as directly from government or from the NHS. And we're trying to whittle away at some of the unnecessary things that practices are asked to do. We want to retain the improvements and the reduced workload of appraisals, using the 2020 template that was agreed this year, and we hope that will become the basis of appraisal going forward. And we also have made some simplification to the contracts by transferring the cervical screening additional service into essential services. This makes no difference to practices in terms of what they do. This just reduces some of the words within our contract itself, so it makes it a little simpler. It's worth mentioning as well, what you, I'm sure, already aware of, that throughout the pandemic, GPC England have been striving to ensure that practices receive the necessary support and income protection. So that's been in place for the last few months and will continue for the rest of this year. The £150 million that we secured, £30 million per month from November to March, has been really helpful in enabling practices to expand their workforce and to provide additional support for other areas of their pandemic response. As I've mentioned, appraisal has been voluntary for much of the year. It was suspended for the first half of the year. And we've secured funding, not just for the COVID vaccination programme, but then additional funding for visits to care homes, for residential settings and home visits, as well as the additional costs, particularly at the beginning of the year, when we had to rebook those second appointments and the additional admin support when Pinnacle wasn't working as it should have been. As a result of the huge work that practices have done, we've been able to achieve well over 70% of the vaccinations that have been delivered. So a massive thank you for a massive achievement that is well recognised by general practice. We achieved the 50 million first dose target before the 14th of February target, and we'll probably be well on our way, I guess, once the vaccine supply increases again in March to achieve subsequent targets that are set for us. The priority groups 5 and 6 will start to be are being immunised at the moment, but it's the second doses that we will now need to be focusing on, and again from March, and we're pushing NHS England to give guaranteed delivery dates so that all sites can start to book people in and give them confidence that they're going to get their second dose. But we're doing this alongside all of the other things as well. So not just our response to care for patients with COVID-19, and thankfully the number of cases are now reducing, but also the long-term issues of long COVID and also the other business as usual. We shouldn't forget that practices are still delivering care to countless thousands, millions of patients every day with other things other than COVID. And I think that's something that we need to recognise as well. We're starting to talk to the government and NHS England about what will happen in phase 2 with vaccinations for those patients under 50. You'll know that the current enhanced service only applies to patients in cohorts 1 to 9. And then also, you'll have seen stories now sort of around whether we will need to give boosters to our patients in the future. And if that happens, then again, general practice will be well placed to deliver that, whether that's something we do alongside our flu program, whether it happens at different times, we're yet to know. So I think this very much depends on the science that is still emerging. One area finally to focus on, despite everything else that's going on, we are facing yet another NHS reorganisation. This is now within the government's white paper that was published just a few weeks ago, and we'll put integrated care systems, ICSs, on a statutory footing. So it's something that practices, PCNs, and LMCs particularly need to be very aware of, need to be engaging with their ICS and their CCGs on at the moment, because CCGs will no longer be with us in a year's time. Instead, the ICS will have an NHS body role, which will be responsible for day-to-day running, and that role, or that body, must include a representative of general practice. We would expect that to be a GP, although it's not spelt out that it should be a GP, but I think that undoubtedly will be the case. So it's important that LMCs are central to ensuring that this is done appropriately. Alongside that, the ICS will have a health and care partnership, which will be a wider body bringing together NHS, local government and partners, and in terms to support the integration and develop a plan to address the system's health, public health and social care needs. So more strategic views from regional bodies. But as well as that, the ICS has to put in place a replacement for CCGs, because clearly in local authority areas, former CCG, former footprints, there will need to be place-based joint working between the NHS, local government, community health services, and other partners such as voluntary and community sector. So that will need to be resourced, it will need to be supported, and we will need to ensure that general practice has a equal footing sort of in those arrangements. So that needs proper resourcing. We know historically CCGs have funded local leadership sort of from general practice, whether that be through additional support for PCNs, whether it be clinical lead of mental health or cancer roles or cardiovascular roles, or whether it be medical director roles within the CCG themselves. GPs have played a pivotal role in leading local organisations and making changes in their local organisations for the last few years, and we need to ensure that continues and is built upon, not reduced. There will also be a focus on improved data sharing, and also nationally the Social Health Care Act of 2012, 75 competition legislation will be repealed. So the focus going forward will be very much on collaboration between organisations, not competition with each other. We also will be seeing an enhancement of the Secretary of State for Health and Social Care's powers to direct NHS England around service provision. We need to watch that very carefully and make sure that that is not misused. So finally, in summary, this contract package is minimal compared with many other years, but will ensure that there is above inflation practice funding for practices, and we'll see a significant level of increased funding for PCNs. There's been improvements to the vaccination immunisation arrangements with a clear item of service payment, and there's additional funding for QOF, but most of QOF remains as it was, including the QI indicators. There's an increase in the ARF workforce options, and 50% of funding for the mental health worker will be provided by the Mental Health Trust or other comparable organisation. There's a delay in all of the service specifications and the IAF until we can really understand what's going to happen with the pandemic going forward. Because our focus must be on supporting practices with their vaccination campaign, and the ongoing work that will come from the sequelae of the pandemic. We also need to recognise that our staff are exhausted and tired and need time to rest, and we cannot be expecting them to go straight from dealing with a pandemic into dealing with sort of other expectations that are placed upon them. So we need some breathing space before that happens. We need to also bear in mind that whatever else we do, we have to keep our eye on the NHS organisational changes, because they will set the scene for the future years, and I'm sure your LMCs locally will be doing that. Thank you very much.